Hello, this is Shadi Reis from MidStar Washington Hospital Center. This is CVI YouTube channel. With me is Mohamad Kabach. He's from University of Miami, JFK Medical Center. Welcome, Mohamad.
Thank you, Shadi, for having me. It's a great opportunity.
Yeah. Today's day one from CVI, a lot of action happening, but we have this case recorded to share the knowledge beyond the conference for people who missed the conference. Please go ahead with your interesting TAVR complication case.
Sure. So the case basically is about coronary obstruction months after an implant. And the goal of this case is first to understand why do we talk all the time about TAVI position, to understand the mechanism of coronary obstruction in TAVI, and to realize how important the position is and what factors that plays an important role in the position. So I'll go ahead and start. This is an 85-year-old woman. She presented to us from an outside facility 5 months after her valve put in. She basically underwent Medtronic self-expandable core valve for severe aortic stenosis 5 months prior to her presentation to our facility. She came in, she still had some recurrent angina in addition to exertional dyspnea with orthopnea and worsening lower extremity edema, which she really didn't have before her valve was put in. So in exam, she had normal vital signs. She did have an elevated JVP in addition to bipacer crackles and 2+ lower extremity edema. So she was admitted for further evaluation. Her lab pertinently came back positive for an elevated troponin, which trended up to 1.9. She had an EKG, which showed paroxysmal atrial tachycardia and severe diffuse ST depression suggestive of ongoing ischemia. So this is her chest X-ray. Didn't look that bad on day one. She was admitted, treated with diuresis, received ACS protocol with heparin per ACS protocol, basically. Due to her significant systolic dysfunction felt on exam, she underwent a 2D echo, which was done stat at the same day, and that showed severe LV dysfunction with ejection fraction of 35% compared to her prior echo 5 months right before her TAVR with an ejection fraction of 45–50%. So due to her worsening clinical case and her symptoms, we decided to go ahead and do diagnostic angiogram. And what we did is we attempted to engage the coronary arteries multiple times, but that, different catheter, including a L1, she had JL catheters. I can't remember how many catheters we used, but despite all these attempts, we couldn't cannulate. So we did ascending aortic angiography, and we noticed that the valve was put in too high, preventing selective or non-selective coronary angiography. So if any lesion was found to be there, we couldn't really cannulate to see it. So she had a SWAN, she had an index of 1.3 at that time. She was just heading south very quickly. We were able to cross the aortic valve after multiple attempts, but you can see her LV function is extremely down, and her coronaries are filling during systole and diastole, but very, very poorly. Unfortunately, we were able to get some baseline pictures just to see if there was possible LED obstruction that we couldn't really see and through coronary angiography. But at that time, she was just getting sicker and sicker. We did go ahead and put an Impella CB device for cardiogenic circulatory support. However, she passed away due to refractory cardiogenic shock. So importantly to realize is one, its coronary angiography post-valve is extremely challenging. There is systematic reviews, article that spoke about the cases of coronary obstruction post-TAVI, and there is certain numbers of patients who develop it, and they cannot review the population of these patients.
This is very important because now the TAVR population is getting younger.
Right.
We're targeting low risk, like ages 60s. So these patients might in 20 years develop CAD or ACS. So it's going to be very hard to cannulate these arteries when they come with ACS. But one thing, we had similar case before. What we did, after putting the pigtail in, we passed a fine cross through the pigtail, took the pigtail out, then the fine cross with a coronary wire was able to just stop below the leaflet advance the wire, and then we're able to do PCI.
So we have attempted this already, and the problem is as soon as we engage, the minute we take pictures, the catheter is out.
I see. With a fine cross.
Yeah.
Yeah. Okay. All right. That's unfortunate. But again, this is probably planning for the implantation wasn't done well, or at least the positioning.
Right.
But that's a good, strong message as we go more forward.
So luckily we got this published. So just to
congrats.
Thank you.
Great, Mohamad. Thanks. So watch this video and the other videos, please, on CVI YouTube channel. This is Shadir Reyes from Marshall Hospital Center.